You are listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, editor of the Journal of Dermatological Treatment and professor of dermatology at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for healthcare professionals.
Welcome to Medscape's In Discussion series on psoriasis. I'm Dr. Steve Feldman. Today we'll discuss the connection between mental stress and skin health, known as psychodermatology. Our guest is a dermatologist, psychiatrist, former director of the University of California, San Francisco Psoriasis and Skin Treatment Center. The leading expert on psychodermatology. Our guest's research interests also include psoriasis therapies, phototherapy, eczema, and quality of life issues. Our guest's wisdom on how to interact and communicate with patients with difficult skin problems has been particularly enlightening. It's my great pleasure to introduce my dear friend, Dr. John Koo. John, welcome to In Discussion.
Thank you for inviting me to do this.
John, we've gone to a lot of meetings together in cities all over, if not the country, maybe the planet. And everywhere we go, I get the sense that you want to visit places that have military history, military museums. And you have this broad knowledge of military history and a lot of knowledge about cultures and history of China, Japan, and Taiwan. I'm just wondering how that informs your view of the world and maybe at patient care.
It's kind of interesting because I'm Chinese, but I was born in Japan and came to US. I didn't speak English until when I was 12. So one thing is that I got exposed to many different points of view. And the reason I was interested in military history was because just like a typical elementary school boy, I was interested back then making plastic models of tanks, aircraft carrier, battleship, and say, wow, this is so neat. And the thing that kind of piqued my interest is I was looking at military history, especially World War II, from both Japanese point of view and Allied point of view. And I find that factually, practically everything is the same. Interpretation, about 95% same. But it's the 5% that's different that actually get my interest in history. And that kind of, helped me to see things from multiple perspectives, even in dermatology. Because in dermatology, how we treat patients, what we think is the right way to do, what we think is the truth. Most of it is okay. They are always like each country has orthodox way of thinking. But if you scratch the surface, or better yet, if you look at how things are viewed outside of US, sometimes it's pretty shocking. You find another 5% that is different, and it could be very different and has patient implication. So I'm glad that I have that kind of upbringing that made me curious and actively look at other countries, other perspectives beyond USA, beyond FDA.
Well, that resonates with me. I grew up in a very small, insular, very religious, Orthodox Jewish community and knew nothing about the rest of life or the rest of the world. I see some of those same principles of how people who come with a certain background see things in a certain way.
Right.
And I see that pattern happening all over between different specialties in medicine and between doctors and patients. Very interesting. By the way, do you collect military memorabilia?
And yes, I do.
Did you once buy a jet plane?
I not a jet plane, but once I was offered to buy a Japanese Zero fighter, and I went to Fargo to give a lecture, but I had some time to kill. So I went to the little aviation museum next to the airport. And there was this Japanese Zero, the real authentic Japanese Zero fighter, which was considered one of the best fighters at the beginning of World War II. And when I was looking at it, the museum people came and said, "Would you like to buy this?" This is right after the Lehman Brothers shock. The economy was bad. So I actually called my wife to see if I can buy it. And she said, fine. Except I didn't know how to put it in my backyard. So I didn't buy it.
All right, that's awesome. Well, let's talk about psoriasis. You've been a leader in the field of psoriasis for longer than I've been in dermatology. Let's talk about what kind of psychological impact does psoriasis have?
Well, the most well documented, which we all see in our practice, depression and anxiety. And it's been kind of taken for granted that people get depressed, they become nervous, they become anxious because psoriasis make them look awful, because psoriasis make them feel awful. But the interesting thing that's happening in the last maybe no more than 5 years is it appears that both the mental problem and the psoriasis problem might actually have a common origin. I don't know how many practitioners have heard of this, but it's called cytokine theory of depression and psoriasis. What happened was that inflammatory cytokines, not just TNF or interleukin 17, but also like interleukin 6, the way that they're elevated in depression is strangely similar to the way they're elevated in psoriasis. And when patients who have no psoriasis, psychiatric patients who just have depression, when they're treated with medications like SSRI, other antidepressant, amazingly, these cytokines that are elevated in state of depression, like TNF, interleukin 17, go down. And how they go down often correlate with psychiatric clinical improvement. So we have talked forever that the skin and mind come from the same ectoderm, but now we seems to have some interesting angle to this, that maybe it's not like one follow the other. Maybe they both happen at the same time. So when we're using medications like biologics, who knows? Instead of just treating psoriasis, we may actually be directly treating depression. Now, anxiety has also been associated with interleukin 23, which, of course, it's one of the more latest thing that we target for psoriasis. So I think that's a real interesting possibility that as a dermatologist, we may be treating mental problem of psoriasis unknowingly.
Oh, that's fascinating. I would have thought, because I only have three thoughts on all issues. One is poor compliance. The other is poor compliance, and the third is poor. I would have thought that maybe if you give people an antidepressant and their energy improves, maybe they take their other anti-inflammatory treatments better. But again, that's just the way I look at the world.
Oh, I'm sure that plays a role too. I mean, it doesn't have to be anything, one way. I'm sure it's a lot more complicated than that.
So when I started seeing psoriasis patients, we didn't have any of the good drugs that I'm prescribing now. We had things like methotrexate and cyclosporin,
Yes.
oral retinoids, things that helped but didn't clear people up. And if patients did get clear, I'd lower the dose because I was afraid I was giving people too much of those medicines. I'd cause side effects. We had Geckerman therapy where we'd wrap people in tar, and you know more about that than I do. Back in those days, I think psychodermatology played a much bigger part of my practice than it does today. Is that your impression, or is psychodermatology just as important now as it ever was?
Now, specifically talking about psoriasis, I agree with you. When the treatment works really well, then we don't have so many, we don't need so many psychological interventions, because when we were desperate, we used anything from meditation, mindfulness, hypnosis. I mean, anything that might even help a little bit, we try to add. But nowadays, you're right. The biologics, the JAK inhibitor works so much better, so much safer. So psychodermatology may appear less important compared to the past, but psychodermatology also deal with patients' mindset. And so instead of more like a psychotherapy, what I found myself shifting with the new agents is more like education. I find that even a really good biologic agents to succeed, there are certain mindset that I can anticipate many patients have that can be an obstacle. In fact, there's only three that to me is very important. One is when I talk about these good medications to patients like biologics, first thing and only thing they really ask about frequently is side effect. And what I find is that virtually no patients know too much about comorbidities. So of course I tell them about side effects, which is not too many with things like biologics. But then I deliberately introduce the topic of comorbidities, the risk of no treatment or under treatment, including all the comorbidities, cardiovascular risk, obesity, hypertension, anxiety, depression, arthritis, because I think it's important for patients to be able to have a fair balance. I personally believe nowadays the treatment is so much safer that the disease is a lot more dangerous when it's untreated or undertreated.
Well said.
So that's the one, which is to deliberately talk about comorbidities. The second is this whole terminology of immunosuppressant. That scares people. And if they don't start the medication, it doesn't matter how good the medication is, it's not going to do anything. I use my hand. This might sound odd. One hand represents what is a normal immune function, and the other hand goes up and down, whether it's immunosuppressed or too much immunity. So by raising one arm, I tell the patient, this is what psoriasis is. It's a hyperimmune condition. And nowadays, thank God, a lot of patients have already heard about how inflammation is a bad thing, not just for the skin, but for the whole body. And then what I show is the one hand representing what is supposed to be a normal immune function, the other raised higher is psoriasis. And then I say these medications are called immunosuppressant because we're trying to bring it down to normalize immune function. We're not deliberately trying to immunosuppress anyone, even though something like adalimumab, can immunosuppress with regard to tuberculosis. But some of the newer ones, I don't even know if that is applicable. That demystify this scary term called immunosuppressant. And the third and the last thing I do is that I challenge the notion because I find many patients are brought up with the idea that if you're feeling great, then less medication you take, the better. And unfortunately, that means patients who do great on these great medications, including biologics, they quit. And oftentimes they are too embarrassed to come back to tell me that they're going to quit. So they just don't, cancel the appointment. And they only come back when they are having flare, of course. And that is the worst thing they can do because when you are having flare, I tell patients that then your immune system is not only hyper, it's paranoid. It's a paranoid immune system. I can say that because I'm a psychiatrist. And now the body is really going to make antibodies. So I explain to the patient, even though it takes a little extra time, about secondary failure, about biologic fatigue, and make sure they understand that it's important to be, compliant, adherent. Kind of remind me that Steve, you're the one who put that on the radar for everyone. And ever since I put that as part of my practice, especially for biologic agents, the secondary failure rate really plummeted.
Very good. All right. Well, back in the day, I used to see a lot of depressed people who were crying. I still see crying patients, but often they're crying with tears of joy because they're on a very safe treatment. They don't have any psoriasis anymore. But depression is such a common problem. It's probably still more common in our psoriasis patients. What kind of screening should dermatologists be doing in our psoriasis patients?
Well, the most important question to me in terms of screening was the depression present before psoriasis even came into the scene. Because in my experience, most of my psoriasis patients, depression happened with psoriasis. Before that, they didn't have any particular psychiatric problem. So for those patients, if anything, in my opinion, we need to treat more aggressively. And well, what about those people, who had depression that predates psoriasis, especially with use of medication with, some depression warnings like apremilast, like brodalumab. Then my approach is, it's not like, wow, gee, you have history of chronic depression, so I'm not gonna give you this medicine at all. Now, of course, if there are other medications available, that might be easier. But sometimes I do need to use those medications with depression warnings. Then what I like to do is to first let them know that sometimes FDA put warnings that may not be scientifically validated. Apremilast, for example, I know for a fact that 4 people committed suicide in worldwide apremilast clinical trial phase 2 and phase 3, and all of them were only on placebo. And when it comes to brodalumab, if somebody really needs something that powerful, I don't want to deny the patient the treatment, but I'm pretty aware of the fact that very few people, I believe only 3, who actually committed suicide and was determined to be suicide. So I explained those. And lastly, I asked them one critical question, which is, if for some reason, if medication like apremilast or maybe brodalumab, if you felt that it is making you feel more depressed, can you stop the medication and let me know right away? If the patient say yes, then I'm not worried. If the patient has mental health professionals who follow them, and many of the people who have mental health problem predating psoriasis, they usually have a mental health professional working with them anyway, then I would work with them. And that's that way I will feel perfectly comfortable using this medication when I have to.
Okay, so there are warnings, and they may not be particularly meaningful, but psoriasis patients can often be depressed, so screening is probably a good idea either way. We could do that with a physical exam, looking at patients' eye contact and asking them questions about their level of fatigue and sleep. But if you like formal measures, depression can be assessed with the Patient Health Questionnaire 9, which is better known to most people as the PHQ-9. I feel like it's sort of maybe a knee-jerk reaction on my part that if I think that they might be depressed, I should ask them if they're having suicidal thoughts in order to decide if I need to refer them acutely or not. Is that a reasonable way to think about this thing?
Yes, I think that's perfectly reasonable. There's some kind of a myth that if you broach the topic of suicide, maybe you're planting the idea. That has been debunked for decades ago. Even back when I was a psychiatry resident back in, 1980s, it's already been debunked. So there's nothing wrong with asking that directly.
All right. Well, John, before we wrap up, do you have any other practical tips you want to share with our audience?
When we talk about psychodermatology, obviously people will naturally think about patients. But I think it's also good to think about doctors. I think the reality of these good medications like excellent biologic is that still majority of dermatologists do not prescribe it that often. It's a small minority that prescribe most of this medication. And I don't know exactly what the reluctance is on the part of the provider. But when the patient is feeling depressed, anxious, maybe feeling social phobia, any kind of that type of information, the best thing you can do for their mental health is to get rid of psoriasis. So more they have mental problem, the more aggressive we should be. And that would be my parting shot.
Outstanding, John. Today, we've had Dr. John Koo discussing psychodermatology. We've talked about the impact of psoriasis on patients' lives and the depression and anxiety they get, how the comorbidities of our treatments may be worse than the risks of the medication, and that the best thing to do for our patients' mental health if they have bad psoriasis is to treat their psoriasis. Thank you so much for joining us. This is Dr. Steve Feldman for In Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on psoriasis.